So good afternoon. Hopefully everybody enjoyed the lunch and also the great talk like Dr. Desai shared with us. So we're going to have a couple of cases, or at least total of 4 cases, I believe, and kind of going through the exercise of how to use this medication in real case. And yeah, I want to share with you a case that I saw in my clinic not a long time ago. And I like this kind of picture here about the weight loss and weight gain. It's really a challenge for all of our patients. We talked a lot about continuing this medication to lose weight, and then there is always challenge of weight gain again. So with that one, we kind of going to go through this case of a 50-year-old white female who got, we received consultation for weight loss. Past medical history of anxiety, ethanol, alcohol abuse, gastric bypass. So patient already has gone through bariatric surgery and is here for obesity management. Parotid adenoma, she had a surgery for that adenoma in 2011, so about 14 years ago. ADHD, iron deficiency anemia, PCOS, C-section, cholecystectomy, and breast reduction. So this is a real patient, has a lot of problems. Usually our patients, when they come, they have a list of past medical history. BMI was 58, weight 345, and height of 167 centimeter, if I go with the SI unit. Bariatric surgery was Roux-en-Y and was done at age 30, about 20 years ago, when her weight was 315. And she also gave me history of hyperphagia, reported childhood obesity, and a strong family history of obesity. Just to give you some information, I also, not only I work at University of Colorado, I also work at VA Hospital, which is our veteran hospital. Our VA system in the US has a great EHR record, medical record, so I was able to gather a lot of information from patients. So this patient used to be in Army, so I can tell that this patient to join Army shouldn't be that obese. So this is a problem that happened after retirement from Army. So just to give you a small picture of Roux-en-Y to refresh your memory that how Roux-en-Y happened. So this is post-surgery. They keep a small pouch of the stomach and they connect it to the small intestine. So they bypass majority of the stomach, and that's how the weight loss happens after that. So this is the real patient medical record that you see that from 20 years ago, from 1999, her weight was 227, and they come to VA hospital after they retire from active Army. So she went to outside hospital or outside VA center to do her bariatric surgery. And I was able to get her weight just before surgery, as I mentioned, went all the way to 315. So she did bariatric surgery in 2004, again, exactly 20 years ago. And she lost weight, significant amount of weight. She came to 170. So from 315, she dropped to 170. But when I saw her again, her weight was 340, even higher than her weight prior to surgery. So what happened? I mean, one approach is to give her some advice and counseling on lifestyle changes and start pharmacotherapy. But the reason I'm bringing this case that usually these cases are more complicated. Obesity is a very complex situation. You need to get a lot of history and try to personalize your care and give patient the best care possible. So I started talking to patient. Actually, I went to the room. This is a patient who my fellow saw. I came outside. I said, okay, this is a case that we need to start GLP-1 weight gain after bariatric surgery. Let's do it. And I said, we need to find out why this patient failed bariatric surgery. Maybe there are some problems here that we need to approach. So the first question I asked the fellow, what are the predictors of failure to maintain weight loss after bariatric surgery? And we looked at the literature, and you can divide it into some anatomical or surgical factor. So when they do this kind of surgery, as I mentioned, they bypass, they keep a small pouch and they connect this remnant of the stomach to the small intestine. And sometimes that one starts dilating, so a lot of food can cross stomach and go to small intestine easily. So dilation of that is one of the reasons for surgical failure, or that stomach pouch can get larger, can maintain and tolerate more food. And the other thing is, they typically, this is small pouch of a stomach is not supposed to be connected to this bigger pouch of a stomach. So sometimes there is a fistula happens, so the food, rather than going to a small intestine and bypassing the stomach, can go to the remnant of the stomach. And so some surgical failure or failure because of some surgical factors can happen. But our case actually went to bariatric surgeon, and that was not the problem. So there are some social demographic that they have a higher chance of failure after bariatric surgery. Usually older age, being single, low socioeconomic status, people who work at the kind of food-related industry, they usually have a higher chance of failure or higher chance of regain. Not having a full-time job, again, going back to low socioeconomic and low education. What else? What other past medical history that people usually have a higher tendency of regaining? People with a history of eating disorder, like people with a binge eating problem or emotional eating, stress eating, we talked about that. These are the people that regain weight. And another factor, psychological factor, people who have major depression, anxiety, alcohol, substance abuse, impulsive behavior, personality disorder, these are the one. And the last one, genetic. We talked a lot about genetic predisposition, but this is a little bit different. When we talk about genetic predisposition, we talk about multi-genes and that as a complex genetic disorder for obesity or diabetes. And it's the most common reason for, when we talk about genetic predisposition, we are not talking about one single gene, we are talking about multiple genes predisposing people to higher risk. But both in diabetes and obesity, sometimes we have monogenic causes, which is a rare cause of obesity, or in diabetes, we call it monogenic diabetes. There are rare causes, but it can happen. And people who have monogenic variant in obesity, sometimes they regain all of their weight after surgery. Just to give you a little bit information of what is this monogenic diabetes, whether we are testing it or not. Actually, based on Endocrine Society, in people who have early onset obesity before age 5, and people who have also some features of some obesity syndrome, especially hyperphagia, and a strong family history, technically you're supposed to do genetic testing. And to give you an idea, just a brief, very oversimplified pathway about hunger and regulation of feeding, leptin that comes from adipose tissue activates a receptor in hypothalamus, and also GLP-1 and PYY that are incretins, activate a receptor here and activate POMC neurons that at the end, this receptor is very important. MC4R or melanocorticoid 4 receptor is very important, that activation of this receptor suppresses hunger or produce satiety. When there is a mutation here, this is problem with people not feeling full, or they have hyperphagia. And the genes that are tested are from here, leptin receptors. I can show different cartoons. So leptin receptor can have mutation, like PCK1 can have mutation, MC4 can have mutation. Some of the receptors in pathways or can have mutation resulting in not feeling full and feeling hungry all the time and cause having hyperphagia. So in the US, we have a panel of tests for the 79 genes actually that they can test for obesity. Again, this is not a common form of obesity, but can happen. And the reason that now we started testing for it, because we have a medication for it. And that medication is setmelanotide, that, as I showed in the previous picture, setmelanotide is agonist of MC4 receptors. So if there is any problem in that pathway and the receptor cannot be activated, setmelanotide can activate the receptor and cause significant weight loss. So if you find people who have mutation in this pathway, either POMC, PCK1, leptin receptor mutation in addition to MC4 receptor mutation, treatment with this medication can make a major difference. It doesn't work in regular obesity, but like in people who have obesity for different reasons, it doesn't work, but in people who have mutation, it works really well. So we thought about this. We tell you just upfront that we checked that that patient was negative, but that hyperphagia family history kind of made me test about that. But the information that at age 18 she joined Army, that kind of gave me the less likelihood that probably she didn't have the monogenic obesity. So I started getting more information about patient, what happened. So she told us that 1 year after her bariatric surgery, she went through divorce, which was very difficult for her. Then she had problem with depression and alcohol, started drinking a lot alcohol. This alcohol problem really became serious, and also depression got worse, and she had several rehab admission, and she started even using some narcotic painkiller. And because of all of this problem with alcohol and drug abuse, she lost custody of her son. And her parents actually, her child grandparents took the custody and started raising him. So this is all throughout the weight loss. And when she lost her son, she said that was the last straw, and she really put her in a bad situation. And this is when she started eating. She started stress eating. She remained sober with the hope of getting her son back, but meanwhile, her father passed away. And again, she relapsed and started using a lot of alcohol. And she even committed suicide, but it wasn't successful. And so what I'm trying to tell you from this true story, that sometimes weight, it could be just a manifestation of a lot of stress, a lot of problem in the background. Maybe you don't have that much alcohol abuse problem in this country, but I'm sure there are a lot of other problems that to deal with, people start eating food, and not because they enjoy, not because they are hungry, but obesity could be manifestation of a lot of other mental problem or a stress in the life that you need to, we kept mentioning that you need to kind of treat the root cause problem. Sometimes root cause problem is not just obesity, even you have to go deeper and investigate why this person is so obese and why is using food as a treatment or as a stress reducer. So now that I have all of this information, patient comes to me, she has been sober, her weight is 350, and I have a better understanding why she gained all of this weight back. What should I do? Should I start medical therapy or not? What you guys would do? Do you give GLP-1 to this patient now? After I was advocating for GLP-1 for almost everybody. Any comment?
I think the concern here will be, like, there is lots of psychological issues with her, right? And there was this suicidal attempt before. So will you give a GLP-1 knowing that that might aggravate the situation?
Exactly. So a lot of mental disorder, a lot of things in the background that you think you should work with and try to maybe get some mental health counseling, some work. And the question, it was brought up in a patient, because when you look at the package insert, there is a caution about giving it to people with history of suicidal attempt or suicidal ideation. So going through different medication, actually GLP-1 is the least of our concern. All other medication, when there is suicidal ideation or major depression, that's a big no-no, like naltrexone, bupropion, history of alcohol use, opioid use, seizure, especially with bupropion, and suicidal ideation is absolute contraindication. Phentermine, topiramate, again, major depression, suicidal behavior is contraindication. So non-GLP-1 is not useful, so you cannot give it to them. Orlistat, the patient had, I don't know if I mentioned it in my presentation, but patient had chronic diarrhea. Even she takes some medication to control that. I don't know if it's IBS or what it is. But Orlistat was also a problem. I'm not going to give it to a patient who already has a lot of diarrhea. Then we are left with the GLP-1 or semaglutide. And since patient is a veteran and comes to VA hospital, actually our VA covers all of this anti-obesity medication. So insurance coverage was not a problem. Should I give it or not? So the question is, what is the link between suicidal ideation and weight loss? And some of these older medication, they directly affect the CNS and might increase the risk of suicidal ideation. But there is also some data on bariatric surgery people. Actually, this data came from VA hospital. They looked at the veterans who underwent Roux-en-Y bypass surgery in the about period of 16 years from 2000 to 2016. And they looked at the rate of suicidal ideation in people who went through Roux-en-Y bypass versus the control, that they didn't do surgery, remained obese. As I mentioned, most of us, before looking at this data, I thought, if people lose weight, simply they should feel happier. But that's not as simple as that. People who had surgery in this cohort, they had about 20% higher risk of suicidal ideation than non-surgical control. And again, the hypothesis is in people with depression, usually they use food to comfort and console themselves. So if you take away food because of bariatric surgery or some other reason that people, they don't want to eat food or they won't feel happy with food, then they might have higher risk of suicidal ideation. So overall, suicidal risk is higher in veterans than general population in the US, but on those who went through surgery, 20% higher is significant. And now people are very concerned that maybe in people who are taking GLP-1, which cause about up to 20% weight loss or 15% weight loss, maybe the risk of a suicidal ideation is higher, or we need to be concerned. This study was published just recently, and it is a retrospective kind of real-world study looking at EHR, about 240,000 people who were overweight and they took GLP-1, and 1.5 million people who were on GLP-1 and had type 2 diabetes. When they look at this large population and they did matching with the control, again, retrospective, real-world data, there was no signal of increased risk of suicidal ideation. So it kind of made us feel better that looked like GLP-1. There was a lot of concern about that, and even FDA is collecting data on the suicidal risk. But overall, at least from real-world data, we don't have any evidence in favor of increased risk of suicidal ideation.
So this is retrospective. So they looked at charts, right? So
Yes.
is it documentation of suicidal ideation? So what if it was not documented then?
Exactly. So that's the risk with doing retrospective. Maybe that suicidal ideation, especially if it was attempt doesn't happen as frequently as ideation, but at least from what it was documented in the chart, because a lot of people, even though we are trying to help people and try to make it easier for them to report this kind of ideation. There are a lot of 800 number or hotline that people can call to report ideation. A lot of people keep it to themselves and they don't talk about it. So the data is not as accurate. But FDA also, at least in the US, because of the concern, is trying to collect this information, trying again to gather information about suicidal thoughts or action in people who are taking GLP-1, and this is kind of post-marketing reporting, and there is nothing significant yet. And in the large trials, when you put the meta-analysis, the number of the events, ideation or attempt is so low that hasn't been any signal. So overall, as a practitioner, we think about it, but it's not, I won't consider it a contraindication. I still prescribe, but maybe I will be a little bit more careful. So in this case, so I just want to go through that information with you, share with you that should we be concerned or not. I would say probably I can go ahead and prescribe it, but I gave you a history of parathyroid adenoma. Any concern here? Somebody who has adenoma in the parathyroid? You heard about medullary cell carcinoma of thyroid is a contraindication. And if somebody has medullary cell carcinoma, we shouldn't give it. But parathyroid, nothing to do with medullary, is it? How many endocrinologists in the room? 2? Okay. Yeah, this is a little bit more for endocrinologists, but parathyroid can be kind of related to medullary cell carcinoma through MEN syndrome, multiple endocrine neoplasia. MEN syndrome is, especially type 2, is a syndrome cluster of problem with the medullary cell carcinoma of the thyroid, parathyroid adenoma, and also adrenal and pheochromocytoma, sorry. So type 2 could be medullary cell carcinoma and also parathyroid adenoma. So if we see parathyroid adenoma, especially if you want to start a medication that you're concerned about medullary, you should test it. So just to be on the safe side, I decided to do the ultrasound of thyroid and check calcitonin, and both of them were okay. So I felt more comfortable starting it. A lot of colleagues asking us if a patient has thyroid nodule or a patient has history of thyroid cancer, can I start GLP-1? No problem. The only one is medullary cell carcinoma. And medullary cell carcinoma is very rare. So most of the thyroid cancers are either papillary or follicular. So you don't have to stop or not consider GLP-1 because of the other type of thyroid cancer. And if somebody has thyroid nodule, again, you can check for it, do FNA or do a calcitonin, make sure it's not medullary. Otherwise, you can start the patient on GLP-1. So we did ultrasound and calcitonin. They were normal to just give us some reassurance. We did genetic testing, so I talked to you a little bit about monogenic obesity. Is not common, but it can happen. And fortunately, that panel right now in the US is free of charge because the company who has setmelanotide, they have made a drug that they don't have that much usage. So they are really looking for people with monogenic obesity. So they sponsor this obesity panel and they are giving that test for free to everybody who want a test. So we started Wegovy in this patient with a close follow-up and mental health. So I just want to share with this case with you. And patient so far has lost some weight I mean, she has been happier. So that was my case. Any question?